Hi, my name is Betsy White. I'm an assistant professor at Brown in the School of Public Health, and I'm a co-investigator on the Long-Term Care Data Cooperative. And the purpose of this video is just to provide a brief overview of the type of data that are available in the Long-Term Care Data Cooperative. So this is a map of currently participating providers, long-term care providers in the Long-Term Care Data Cooperative. So you can see at the top of the screen here, as of early August, we had just upwards of 1,900 skilled nursing facilities that are participating, so whose EHR data we have, and that represents over 1.8 million unique residents. And this number continues to grow over time. But just the point to show here is that we have a pretty nationally representative sample of skilled nursing facilities, or nursing homes, and a pretty sizable volume of unique persons receiving care in those organizations that whose data are available to conduct research with. So I'm just going to talk a little bit or highlight some of the key elements within the EHR data, or the electronic health record data. And for those of you who have are familiar with using either Medicare claims or the minimum data set to conduct research in nursing homes, I'm just going to kind of compare and contrast a little bit with those other data sources. So historically, just to put a resident in a nursing home at a given point in time, we had to rely on the minimum data set, and you would have to look at an admission assessment and a discharge assessment, and then you would have to sort of figure out when that person was actually physically in the building on the basis of those assessment dates. So another data point that can be used now with the data co-op data are the daily resident census information that the electronic health record tracks. So on a given day, the EHR knows whether or not the person is in-house, if they're receiving care, if they're in the hospital, if they're on leave. So this is another data point that can be used in conjunction with the minimum data set to identify when the person is actually in the nursing home. Things like vital signs. So these are structured fields, documentation that the nursing staff regularly documents. So things like blood pressure, heart rate, the standard vital signs if you want to track temperature over time, or pulse oxygenation, pain assessments. A lot of granularity there in that data. Also, blood glucose finger stick monitoring. Very important for anyone interested in, diabetes medications, or, research questions around diabetes medications. Things like height and weight. These are, weights are generally recorded at least on a monthly basis. So that's a data point that's currently not available in the minimum data set. So you can track more granular changes in weight over time. Immunization records. So whereas the minimum data set has just kind of basic fields around influenza vaccination and like a generic pneumococcal vaccination, the EHR immunization records offer an opportunity to receive more granular immunization data. And this is going to be a mix of both historical vaccination data and also vaccinations that are happening within the facility. I would say most of the documentation is going to be around the vaccines that are actually administered within the nursing home, but you will have some historical vaccination there as well. So for example, if somebody received their COVID vaccine a year prior to coming into the nursing home, the nursing staff is probably going to document that on admission so that they have that record for that patient. You can also look at, so the immunization records offer an opportunity to look at vaccines that can't be captured in the minimum data set, and also to look at vaccines with a little bit more granularity. So rather than just, did the person receive kind of a generic pneumococcal vaccination, you can actually look at specific types of pneumococcal vaccines that they received. Advanced directives. So things like a do not resuscitate order, do not intubate, do not hospitalize orders. Oftentimes those are entered into the electronic health record as a discrete order, and that may be in addition to documentation that's done on paper. So for example, if somebody fills out a MOLST or a POLST or a state level DNR form, that paper documentation might be in the paper chart, but oftentimes there is a discrete electronic order also entered into the EHR, so that's available for use. Allergies, both medication allergies, non-medication allergies, which is important when people are doing drug studies or other questions of interest. Lab data. Not all of the facilities in the data cooperative, but a good number of them do have integrated electronic lab data, which means that they partner with an outside lab, that when that lab produces results, they produce results directly back into the nursing home's EHR system, and then the data are actually available as structured fields. So for example, if you wanted to track a creatinine over time, to monitor somebody's renal function, or look at some sort of a treatment or exposure on renal function over time, that would be something that you could do in the data. Additionally, we have point of care testing, so that would be like if the nursing staff is doing for example, a rapid COVID test, a flu test. I mentioned earlier about blood glucose monitoring, the finger stick checks that they do at the bedside. So there's some of that point of care testing documentation in there as well. So lots of good granularity there. Probably the highest value data domain within the data cooperative are around medications. And there's two aspects of documentation for medications. So one are medication orders. So these are the actual prescriptions that are ordered by the physician, the nurse practitioner, the physician assistant. And this actually has the discrete fields of what was the medication, what's the dose, what's the frequency, et cetera, et cetera. And then also we have the medication administration records, which is the actual record of administration by the nurse or the med tech who's actually administering the medication to the patient. Now, this is a huge advantage over either using the minimum data set or claims data to try to identify medication use in nursing homes. So just take the example of claims. If you're used to using Part D claims to do drug studies on nursing home residents, there's a lot of limitations to that. One being that when the person is initially admitted to the nursing home and they're under their Medicare Part A post-acute stay, the costs of the drugs are absorbed into the nursing home's Part A daily rate, and because of that, the drugs for that period of time are not visible in the Part D claims data. Another limitation of using claims data for medication studies is that the claim just tells you that a prescription was entered and the pharmacy submitted that claim for payment, but it doesn't tell you whether or not the medication actually was administered to the patient. And that's the key advantage of having the medication administration record, because now you have that added documentation that the medication was actually given to the patient. And same, there are also measures of medications within the minimum data set, but those are only at discrete periods of time, when the assessments are done, and that's based on a look back, and it's self-reported by the facility. So lots of added nuance within the medication order data and the medication administration records. Just to say a little bit more about both of these domains. So first, medication orders. I think the key point here is that so we have on the screen here sort of a typical example of a medication order. Each one of these pieces of the order is a discrete field in the data. So it's not like you're getting a big block of free text that has all of this information in it. There's a variable field for the medication name, a variable field for the medication strength, for the dose, for the route, for the frequency, etc. And then additionally, you'll have start dates, you'll have end dates. So lots of granularity within the medication orders that can be leveraged to understand about medication use in nursing homes. And then medication administration records. So to say a little bit more about this, because if you're not familiar kind of with what this is, so historically, sort of in the old days, and still in a number of nursing homes when everything was on paper, if you would go around to the medication carts in the nursing home, you would see a big binder like what's on the screen here. And that binder would contain, for every patient on that nursing unit, all of the medications that person was scheduled to receive over the course of a month. And you would just have these huge grids, and as the nurse or the med tech was administering medications, they would be, he or she would be signing off the orders in this documentation. So now, in modern day, a lot of nursing homes have switched to now the medication administration record is now an electronic medication administration record, which means we now have each individual administration available as a data point. So the data are at the level of the administration level. So you can see whether a medication was administered, whether it was held, whether it was discontinued. So lots and lots of granularity here. And just to show this visually here, we have two examples on the page here. So at the top of the screen, we have an example for a scheduled medication. So this is a medication that was scheduled to be given once a day. It was started on the 4th of the month, and it was administered daily. You can see the nurse's initials there until the 10th of the month, and then that order was discontinued, and then it was replaced with a new order to give the medication twice a day. And so you can see on the 11th of the month, now you start seeing the nurses beginning to initial the medications being administered from the 11th of the month and onward. An example down here at the bottom is this is an as-needed medication. So again, Tylenol is kind of the typical example here. So the medication is ordered every 4 hours as needed. So when you look at the grid to the right here, you can see that most days the patient didn't need to receive Tylenol. On the 3rd of the month, they received a one-time dose at 10 o'clock in the morning. It was signed off as being given. And then on the 8th of the month, they needed it 3 times that day. So that was a day that they were having more pain, but the rest of the month, the medication wasn't administered. So really important here, the data are available at the administration level, lots of granularity here to leverage. So it's important to understand that we receive data from 2 different electronic health record vendors, and the data elements that are available, there's similarity across vendors, but there are also differences. So what we have in the data cooperative is a common data model. And just to stay with the example of the medication administration record, in both of the vendors that we receive data from, there's some version of a medication administration record, but they're going to be structured a little bit differently. So what our data engineering firm does is integrates those 2 different versions of the MAR to produce basically what's essentially like a standardized medication administration record that is then available for analysis. And it's available for analysis, pulling data from those 2 different vendors, which have conceptually similar data, but data that are structured in different ways. So this is common across all the different domains that are available in the data. But the different data fields from the different vendors are integrated and harmonized so that the data are useful for analysis, pulling from those different data sources. So there are some things that are currently not in the data, but we're hoping to have available in the data in the near-term future, hopefully in the next year or 2. One high priority is non-medication orders. So if you're familiar at all with nursing home care, pretty much anything that happens to a resident has to have an order attached to this. So this includes their diet, if they're on any nutritional supplements, if they need any, modifications to their diet or to liquids, any treatment orders, wound care orders, therapy orders. Once you have a full order set on somebody, you have a pretty good understanding of what's going on with that nursing home resident. So that's a top priority for us to get into the data. Another top priority is integrating structured nursing assessments. So these are nursing notes that are basically in some sort of a template form. So there are structured fields, but then also some opportunities for free text. And we know specifically from both of the vendors that we have some versions of like changing condition notes. So for example, if someone starts on antibiotics, or they have a change in their clinical condition, or they have a change in their behaviors, that would be captured in these kinds of notes. Additionally, the documentation that nurses do on admission and on discharge from the facility, again, a combination of structured and free text fields that we're hoping to have sooner rather than later in the data. Some other items that are in the EHR, but not probably a longer term horizon in terms of when they would be available for research, would be things like interdisciplinary progress notes, which would include therapy progress notes from like physicians, nurse practitioners. Those oftentimes either live in different data systems, so there's a lot more complexity to bring them into the existing data model. So those longer term for bringing those in. The other thing that's further down the line would be anything that comes as like a PDF document. So a lot of data that comes into the nursing home is either faxed, or it comes in the form of a paper discharge summary when the person gets discharged from the hospital, and then that all gets scanned into the EHR system as a PDF. Those things currently are not available, and that's a longer timeline to get those in. But feel free to reach out with questions if, what's there, what's not there. But hopefully this just kind of gives you a good overview of what's currently available, what's not available, and what we're hoping to have in the near term in the data. So we have a website that would encourage everybody to take a look at. The URL is up here on the top left, the ltcdatacooperative.org. And we have a copy of the technical user guide there, which provides more detail on individual data domains and variable fields. And then we also have some descriptive characteristics of the actual data that are available there as well. So thanks everyone for listening. Feel free to either check out our website and reach out with any questions. Thanks.